We're going to get the deliberation started for the session 2 here. My name is Raghu, Montaganahalli. I'm with the Indiana University School of Medicine. And with me, I have Dr. Ashley Peters from Loyola University here. With that note, I have a few announcements quickly here. I just want to ask all the presenters to disclose any relationship to the industry prior to the start of your presentation. And also, please make sure that you switch off your phones and pagers are silenced. And the next session is going to start at 3:45 for the New Horizon after the break. So mark your calendars there. So with that, I will invite Dr. Boshra Al-Ibrahim to present his work on the 25 years of management of popliteal venous aneurysms.
Good afternoon. So the fellow couldn't be here today, so I'm presenting. I'm the senior author of this study. So we have no disclosures. Popliteal vein aneurysm are rare vascular disease that can lead to treacherous complications, including DVT and pulmonary embolism. There is limited data on the management of this disease. The objective of this study was to review the clinical presentation, management, and early outcomes in patients with the popliteal vein aneurysm. This was defined as a sacral fusiform vein enlargement of at least 2 times the average diameter above and below the aneurysm. Demographics, intraoperative details, and outcomes of all consecutive patients between 1998 and 2022 treated either surgically or conservatively were analyzed retrospectively. Patients were compared by type of aneurysm and the presence of symptoms. Endpoints were 30-day major adverse events and long-term graft patency and reintervention rate. There were a total of 54 patients, 34 symptomatic and 20 asymptomatic. With a median age of 63, the gender distribution was similar, and the asymptomatic patients were older. The most common risk factors, comorbidities, were hyperlipidemia, superficial vein insufficiency, and hypertension. Hypercoagulable state was more present in symptomatic patients. Among all patients, there were 37% saccular without thrombus, 20% saccular with thrombus, 39% fusiform without thrombus, and only 4% fusiform with thrombus. Symptomatic and saccular aneurysm were significantly larger, 30 mm, 25 mm respectively, compared to asymptomatic and fusiform. And among all aneurysm, the left side was more common. Also, 80% of the aneurysm were in the P2 popliteal segment. The most common sign was swelling, 59% of patients. Importantly, mild symptoms such as discomfort or mild pain were more common with the fusiform aneurysm, while severe pain and pulmonary embolism was more common with the saccular. 30 patients were treated conservatively, 15 symptomatic and 15 asymptomatic. In the symptomatic group, most of them had the mild symptoms, were small aneurysm without thrombus. 24 patients underwent surgery, 19 symptomatic, 5 asymptomatic. In the surgical group, the majority, 90%, were saccular. If you remember, these were larger than fusiform with more thrombus and more severe symptoms. All were electively done, and all were done through a posterior approach. Again, a majority were in the P2 popliteal segment. Lateral venography was the most common procedure performed, with only 4 patients undergoing interposition graft, 2 gray saphenous vein, 1 spiral gray saphenous vein, and 1 internal jugular vein. There were very few major adverse events, 1 pulmonary embolism in a symptomatic patient, 2 wound hematoma, 1 requiring drainage, 1 acute graft occlusion treated with the thrombolysis, and 1 wound dehiscence. The median hospital stay was 2 days. 88% of these patients were discharged on anticoagulation and antiplatelet for at least 3 months. In the surgical group, during the median follow-up of 29 months, There was one death for renal failure. There were no graft occlusion, no de novo symptoms. 4 patients had recurrent symptoms, 1 required intervention. This patient had, as an index procedure, a lateral venorrhaphy and developed, weird enough, a recurrent aneurysm, which was treated with the interposition graft. Half of these patients were on antiplatelet at the last follow-up, and about 1/3 on anticoagulation. In the conservative group, during the median follow-up of 32 months, there were 2 unrelated deaths. 1 patient had the de novo symptoms, no requiring surgery. 1 patient had the persistent symptoms, no requiring surgery. And about 2/3 of patients were either on antiplatelet only or anticoagulation plus minus antiplatelet. Unfortunately, we have no enough imaging follow-up to determine the aneurysm growth rate in the conservative group. 3-year primary and the assistant patency were 95% and 100% respectively. 3-year freedom from reintervention was 94% for symptomatic and 100% for asymptomatic. 5-year survival was 92% for symptomatic and 95% for asymptomatic. So in conclusion, popliteal vein aneurysm had a similar gender distribution, were more commonly saccular and symptomatic. Presence of symptoms was associated with a larger aneurysm diameter. Compared to fusiform, saccular aneurysms were larger in diameter, more associated with the severe symptoms and the intraluminal thrombus, and more likely to undergo surgery. Surgery was offered for severe symptoms or in case of an aneurysm greater than 2 centimeters with the concomitant thrombus. Surgery had very few peri-procedural complications and excellent long-term primary patency. For asymptomatic or pouchy symptomatic popliteal aneurysm smaller than 2 centimeters without thrombus, conservative treatment in this study was safe and durable. Thank you.
So the paper is open for discussion while we are getting someone to come over and ask questions. My question, Dr. Talleria, is on the decision making. You know, you described about 3 different methods, how you reconstructed the popliteal vein. Can you tell us how do you choose them, or is just the operator dependent, or was it a specific case dependent?
Right, so the approach posterior versus medial, it depends the location of the aneurysm. If it's in the P2, if you want to use the arterial classification, if it's in the P2 popliteal segment, it's easier to go for a posterior approach. If it's a saccular, which means only one side, one edge of the wall is aneurysmal, you can just remove the part in the overzone, which is called the lateral venorrhaphy. So if it's fusiform, it's still in the P2 only, you can still do a posterior approach, but most of the time you have to replace the entire vein because otherwise you leave aneurysmal wall. And that maybe was the cause of that recurrent popliteal vein aneurysm in the follow-up that eventually required the interposition graft. For longer aneurysm, including P1 or especially P1, proximal P1, a medial approach like a venous bypass would be more appropriate.
Dr. Zayed?
Yeah, Mohammed Zayed, WashU. Great study and fantastic to see a great big cohort of patients with this pathology. Oftentimes people have duplicated popliteals, so I'm curious, are you seeing aneurysms in just one of the popliteal veins, or do you see pathology in both veins? Do they communicate differently typically? And then also, can you comment on the etiology? Do you think this is traumatic, or what do you think is causing these types of aneurysms along the distribution of P1, P2, P3?
Right, right, absolutely. Thanks for the great question. So the popliteal vein is always coupled. Usually it's the other one is very small, either we don't see, or it's kind of seems almost a collateral. We didn't see any bilateral popliteal, any aneurysm that would involve both popliteal vein on the same side. In terms of the etiology, there was only one traumatic patient, if I recall well. The other one, you know, my fellow one day comes to me and says, there is quite a bit of incidence of superficial vein insufficiency. But I don't think that's the case, because otherwise we would see much more popliteal vein aneurysm if there was a direct correlation between a superficial vein insufficiency and the popliteal aneurysm. So I don't have an answer for that. Sorry.
I do have one more question. So to my knowledge, residents and fellows don't get to see this often. So what was the driving force to presenting this study now?
For this reason, because we don't know much about this disease. It's a rare, and we face one or two in the entire Mayo enterprise, 1 or 2 per year. So when I see that, I kind of read the literature, I talk to my colleagues, but still it's kind of nobody really knows the outcomes. Well, this study kind of gives a little bit more light on lay outcomes. Maybe we could be, based on this study, we could be a little bit less aggressive if it's a small aneurysm with no symptoms or mild symptoms and no thrombus inside, of course. Maybe we can just do conservative treatment and just strict follow-up.
Thank you.
You're welcome.
Thank you.
Absolutely. Thank you.
All right. So our next study is endoscopic vein harvest of great saphenous vein is associated with worse long-term outcomes in infrainguinal bypass patients, presented by Dr. Mohammed Choror from the University of Iowa.
Thank you for giving me this opportunity to present this research, which was a collaboration between the University of Iowa and Henry Ford Hospital in Detroit. We have no disclosures. Endoscopic vein harvest is currently performed in 90% of coronary artery bypass grafting utilizing the GSV. Most recently, the regroup trial showed equivalent outcomes between the two techniques when performed for CABG. In this study, only experienced harvesters were allowed to participate. In vascular surgery, open harvest remains the preferred method for lower extremity bypass. This is because we have no RCTs, single center studies showed incongruent results, and a VQI analysis in 2015 showed superior outcomes with open harvest. As such, our objectives were to compare outcomes between the two techniques when performed for lower extremity bypass, as well as explore if there has been any improvement in outcomes with endoscopic harvest over time. We utilized the SVS VQI lower extremity infrainguinal bypass registry. To limit heterogeneity in our sample, we included only patients who had a common femoral artery inflow site. We also excluded patients who had acute limb ischemia, trauma, aneurysms, and in situ bypass. To limit heterogeneity between groups, we performed a 3-to-1 propensity score matching between the open and the endoscopic harvest group. For the statistical analysis, we performed a chi-squared analysis for short-term outcomes and Kaplan-Meier analysis for long-term outcomes. After matching, we had 7,929 patients in the open group and 2,643 patients in the endoscopic group. As you can see, the standardized mean difference is less than 0.1 for all relevant variables, which confirms proper matching. Similarly, groups had similar distribution of case urgency, vein configuration, and outflow target site. For short-term outcomes, open harvest was associated with an increased rate of surgical site infection. To note, surgical site infection is captured if the patient was prescribed antibiotics for their wound complication or if there were positive wound cultures in the chart. Other wound complications, including hematomas and dehiscence, are not captured. Similarly, open harvest was associated with higher length of stay, procedure time, and estimated blood loss with significant p-value despite similar medians between groups. For long-term outcomes, open harvest was superior in both primary and secondary patency for up to 18 months, as shown in these two curves. At 1 year, primary patency was 71% for open and 65% for endoscopic harvest, while secondary patency was 90% for open and 85% for endoscopic harvest. Similarly, open harvest was superior in freedom from amputation and freedom from reintervention, with the hazards ratio of 1.44 and 1.23 respectively. We performed a subgroup analysis in which we looked at outcomes based on the outflow target. Endoscopic harvest was again associated with worse outcomes, regardless of the target vessel, with almost 25% to 50% increased odds of loss of primary patency at 1 year, as seen by hazard ratio between 1.23 and 1.55. Next, we wanted to see if there were differences in outcomes of endoscopic harvest over time. As you can see, primary patency was 59% in 2011 and gradually increased to reach 70% in 2020, which was a statistically significant difference. You can also see that difference evident on this curve, where the light blue line represents primary patency in the 2011 cohort, and the red line represents primary patency in the 2020 cohort. This could be due to advanced technologies in the new endoscopes, or due to the higher experience accumulated by the vein harvesters. Unfortunately, this cannot be known from the VQI database. When we compared outcomes based on technique by years, we saw that open was superior in the first half and became equivalent in the second half. We started with a 13% difference in patency in 2011, 59% compared to 72%. And in 2020, we have a difference of 3%, which was not statistically different. However, it is important to note that this comparison is between unmatched and unadjusted samples, and hence those findings should be analyzed with caution. In conclusion, this study shows that endoscopic harvest was associated with improved short-term outcomes, mostly decreased surgical site infection and length of hospital stay. Open vein harvest was associated with improved long-term outcomes, both with increased patency and increased limb salvage. And finally, endoscopic vein harvest is improving with new technologies and more experience. We believe a repeat outcomes analysis will be needed to reflect those advances in the future. Thank you.
Hi, two questions. Number one, is there any way to control for the quality of the runoff and the vein itself in terms of size? And number two is, do you have a breakup of how many of these were done for CLTI or not? Thank you.
Thank you for your question. We did not include that control in our analysis, but we will certainly look into that in the manuscript. That's for your first question. For your second question, 70% was for critical limb ischemia in both of those groups.
Frank Caputo, Cleveland Clinic. You know, the big difference between a cabbage and a leg bypass, I'm going from here to here, and I'm going down there. And, you know, when they do these cabbage endo harvest, sometimes it comes out in pieces. So did you have any information on splices or anything? Because that might affect your long-term patency where, you know, if you do it open, sometimes, unless you're me, you don't get into the vein sometimes, but sometimes you can get it all in one piece.
Yeah, certainly. So this sample included one vein only, so none of the veins were spliced. This was excluded initially. That's for the first question. For the second question, we also had a similar thought where we thought maybe if the vein is shorter, like in cabbages, we will have equivalent outcomes, and hence we did the subgroup analysis where we looked at the above knee target only, and still, at least between the years 2011 until this day, and open has been superior to endoscopic.
Paul Chrysostom, Loyola. I've done quite a few in the past, endoscopic vein harvest. And when I say I mean the PA that was on the OR has done quite a few for me in the past. And I think that's largely true of every surgeon that's ever done an endoscopic vein harvest. The surgeon almost never does it. And so it's largely a procedure done by an NPPA who is trained to do it. And I think the number one determining factor for the outcome of endoscopic vein harvest is the proceduralist itself, which is why you quoted some of the papers say only experienced endoscopic vein harvesters were included. So because the VQI doesn't really allow for that variable, how do you think you can mitigate that bias, since I think that's probably the number one determinant of the outcome? Thanks.
Absolutely. So just since you mentioned the regroup trial, for the cabbages, there were already 2 trials in New England Journal of Medicine in around 2009 that showed superior outcomes with open. The only difference in the regroup trial in 2019 was that they only allowed the experienced harvesters. So the first take-home message from that was, if we're going to adopt an endoscopic vein harvest method, then we'll have to get the PAs to harvest the veins because they are the more experienced. And I can also say that we also have data from cabbage patients where they looked at the molecular level and at the histological level, where they compared novice harvesters to experienced harvesters, and they saw that there were more thermal injuries, more intimal injuries, more expression of proteins associated with arterial damage and coagulation. So that's totally true. I don't know how we can control for that from the VQI. Unfortunately, this is not part of the data captured.
I have one more question. So you commented about the patency between these 2 techniques. Do you have any explanation as to why you have a poor patency in the endoscopic vein harvest?
Yeah, absolutely. So when you do the endoscopic harvest, there is, at least initially in the first generation endoscopes, you had higher rates of thermal injury because of the cautery used in a very tight space. You have the retraction that you're performing when you're doing your harvest. That is also not as traumatic as you do in the open harvest. And I think this is why the new endoscopes, like just for an example, one companies for the last 15 years have introduced 7 different endoscopes. Like they have 7 generations of endoscopes. And each one of those endoscopes have some sort of at least theoretical improvement, where they eliminated CO2 insufflation, they eliminated the need for a closed tunnel, they now are using bipolar rather than monopolar cautery. So all those can affect, and I don't know if with all those advancements, the quality of the vein will be better now.
Thank you.
I just had a question. Number one, was there a minimum diameter that was set when you decided that the patient was a candidate for, endoscopic venous harvest or not? And the second question I have is that if you have an above knee bypass or a below knee bypass or a tibial bypass, was the technique in harvesting exactly the same? By that I mean, if you have an above knee and you only need a short segment, were they accessing the vein at one level versus the next level and the next level?
Thank you for the question. So yeah, unfortunately we do not know the technique, but as you said, if you want a longer bypass, you would usually require a longer vein. So a below knee target, you would usually need multiple incisions. Even for the endoscopic, usually you'd end up with 2 or 3 rather than 1 or 2 to be able to get the whole vein. So this is one of the limitations of the study. When it comes to the size of the vein, they're mostly in the above 3 millimeter, but I'll have to double check that in our data set.
Thank you. Unfortunately, we have no more time for questions.
Thank you.
Our next presentation will be a systemic evaluation of the impact of contralateral stenosis on the ipsilateral internal carotid artery hemodynamics, presented by Drew Bratt from University of Michigan.
Thanks again for the opportunity to present our work. We have no disclosures. So we all know that contralateral ICA stenosis is known to affect the ipsilateral ICA velocities. This is particularly true in the case of a contralateral occlusion. We've it's been published on this as early as NASCET, where we demonstrated that with bilateral stenoses, the peak systolic velocity may be artificially elevated actually on both sides. And more recent work from the NYU group has shown that those artificial elevations in peak systolic velocity are reversed when you treat the contralateral stenosis. So what's unclear is how ipsilateral ICA hemodynamics are impacted by the contralateral stenosis. And what I mean by hemodynamics are metrics such as the cerebral blood flow, the pressure gradient, and the wall shear stress. If you're not familiar with the wall shear stress, you can really think of it as the frictional force that the endothelial cells are feeling from the blood flow. And these are important because these play a role in stroke risk. So this is a study looking at intracranial atherosclerosis, and they found that wall shear stress and pressure gradient were predictive of recurrent stroke. Studies in the internal carotid have demonstrated that wall shear stress, the area of highest wall shear stress, is actually associated with areas of vulnerable plaque features after carotid endarterectomy. So the aim of our study was to leverage a patient-specific MRI-informed CFD model, or computational fluid dynamics, to quantify the impact of contralateral ICA stenosis on the ipsilateral ICA hemodynamics. So our group has previously developed a ground truth CFD model. This was built using CTA data for anatomy, phase contrast MRI for flow, and arterial spin leaving MRI data for perfusion. And this really provided a ground truth hemodynamic baseline for a patient who had bilateral asymptomatic ICA stenosis. We've used that in two of our group's previous publications. And the general breakdown of CFD, for those of you who aren't familiar, we do this in an open source software called Crimson. But essentially, the high-level view is if you have anatomical data, so in this case a CT, we get a center line and we create a 3D segmentation of the anatomy of interest. And then you create what's called a mesh. And that mesh is important because CFD uses numerical methods to analyze flow. So specifically, it uses these complex equations that I'm not going to bore you about. But the mesh is important because if you zoom in on it, each one of those tetrahedral points is where you're solving these equations for in the computer. So, for example, the anatomies I'll show you are 5 million elements. So we're solving for pressure and velocity over 5 million places across the entire cardiac cycle. So we assumed that extracranial flows are not going to change with different levels of ICA stenosis. So the way we set up this model is we imposed flow. So we provided fixed flow waveforms for anything that was extracranial or outside the brain. And we used that from our ground truth model from the phase contrast MRI data, which we know to be true. We then used what's called a 3-element Windkessel to the intracranial vessels. And the Windkessel's there on the right. Essentially, it's 2 resistors and a capacitor. And it's a way of numerically approximating the resistance and compliance of the distal arterial beds. So that way you can allow for variations in pressure and flow at these arteries. So here's what our ground truth case looks like. You can see the left side has a 25% ICA stenosis. The right side has a 75% stenosis. I'm going to be calling the right side ipsilateral and the left side contralateral for the remainder of the talk. And then what I did is I altered the contralateral stenosis. So I can remove it and make it 0% stenosis. I can make it 75% stenosis. And we did this kind of systematically until we reached a total occlusion, as you can see here. And then we measured the ipsilateral side. So how did that affect the hemodynamics on the ipsilateral side? Oh, well, I had a nice video there that actually skipped, but you'll have to believe me, and I'll go through it here. So this will be a... This is basically analogous to what you'd see on a duplex. This is the velocity profile you'd see on a duplex. This is our baseline case. And when I increase the stenosis to 75% on the contralateral side, you see minimal change to the ipsilateral velocity profile. Again, when I increase that to 90% stenosis on the contralateral side, you still see minimal change to that contralateral velocity profile. But when we get to the 95% in total occlusion on the contralateral side, you see large increases in the velocity profile on the ipsilateral side. And at the University of Michigan, we use an end diastolic velocity cutoff of 110 and a peak systolic velocity cutoff of 230 as markers of a high-grade stenosis. And oftentimes, if a patient has 2 of these on their ultrasound, we may be considering them for a carotid endarterectomy. So you can see on the 95% in total occlusion cases on the contralateral side, that's artificially elevating the peak systolic velocity on the ipsilateral side to potentially warranting surgery. So how about the pressure gradient? So this figure shows, well, it showed something for a minute. Can I maybe have assistance in the back? I'm not sure if I clicked something wrong. My apologies. Thank you. So this figure shows the different pressure profiles or pressure gradients across the stenosis. And it actually is better visualized graphically. So you can see the same trend sort of holds true here. We really don't see a large increase in the pressure gradient until the contralateral side is at 95 or 100% stenosis. And then when we look at wall shear stress, now I've marked the lesion itself in those green ovals. So obviously I'm not interested in what the wall shear stress is at the external carotid artery. I'm just interested in what it is at the lesion itself. So you can see here that the same trend seems to hold true. And again, this is better visualized graphically here. You can see that there's no difference in the wall shear stress until that contralateral stenosis is at 95 or 100%, and then it's significantly elevated. And then lastly, we can look at flow. So here what you see on the blue is the ipsilateral cerebral blood flow, and the yellow, or maize, as the Michigan fan in me says, that's the contralateral cerebral blood flow. And you can see the same trend holds true again. You're kind of seeing flow compensation across each hemisphere until that contralateral side's at 95 or 100% stenosis. So this data shows that contralateral ICA stenosis impacts the ipsilateral ICA hemodynamics, and thus it may impact the ipsilateral stroke risk. Patients with high-grade contralateral ICA stenosis or occlusions have falsely elevated velocities, and per this study, above 95% contralateral stenosis may elevate your ipsilateral velocity above a threshold for repair. I think this data really shows that it's really important to consider the percentage of contralateral stenosis when we're considering repair of an ipsilateral lesion. Thanks again to the committee for the honor of the podium. Thanks to the lab members and my mentors and our funding, and happy to take any questions.
So while someone is coming to ask a question at the microphone, most of this information we know from the ultrasonography, except from the duplex exams. We know very clearly that a contralateral occlusion will automatically elevate the velocity. Tell us a little bit more how this is going to add value in addition to the ultrasounds, number one, and how is it going to make a big difference in your treatment decision too?
Yeah, that's a great point. Yeah, thank you. I think that's a great point. I think one of the things we're probably missing, one of the earlier talks showed plaque morphology. Obviously, this study doesn't focus on that, but I think plaque morphology probably plays a bigger role than we're giving it credit for and than we're currently using in our clinical practice. But additionally, I think the hemodynamics certainly have an important role irrespective of the velocity. So some of our other work has looked at patients with severe grade or high-grade carotid artery stenosis, and there's large variations in their hemodynamic profiles. And as we kind of tease that out and more groups look at this, I think we're going to see that those will correlate to outcomes. Obviously, I need a couple years before I can work on that and have the data to support that. But I think that really we're probably missing the point by using duplex and velocity alone, and that we probably can push it further and make it a little bit more personalized.
So how did you take into consideration sometimes the MRI imaging can overestimate the degree of stenosis? How did you factor that into your analysis?
Really good question. So the anatomy itself was made off of CT. So we use the MRI for flow and perfusion data to really calibrate or prove that what we're seeing is true on the ground truth model. But the anatomy itself was off of CT for exactly that reason.
Dr. Pepinos?
Thank you. You mentioned a paper that corrected one of the stenosis and then reported what happened to the contralateral. Your work, does it correlate with the findings of that paper? Because it looks like as the stenosis increases, there is a change, but truly the substantial change happens at the very tight lesions or occlusions. Is that what they also found when they did endarterectomies?
Yeah, really nice question. So that paper obviously was set up a little different than kind of the question I had here, and they took patients at all levels. So it wasn't just severe stenosis on the contralateral ipsilateral side. And to my recollection of that paper, I don't think they really teased out specific improvement based on original stenosis grade, but they do see that I think it was a third of patients who had the contralateral side corrected changed stenosis category. So if it was a moderate to mild or severe to moderate. So I think the numbers themselves are hard to kind of tease out and compare between the two, but I do think we see similar overall trends.
Really cool study. You know, I'm thinking of my patients that truly have a stenosis on one side and an occlusion on the other side. Sometimes these patients show up with orthostasis, and they're symptomatic because of not enough blood pressure making it to their cerebral circulation. I'm curious, has anybody looked at this relative or artificial augmentation on the contralateral, non-occluded side, relative to systemic blood pressure? Because that seems to me like an important variable that dictates whether or not that artificial augmentation is real.
Yeah, that's a really good thought. I mean, we certainly didn't look at that in this study, and to my knowledge, I'm not aware of anybody looking at that. The majority of what people have looked at in this and has been published on is on collaterals, and there's been some papers that have touched upon your point based on the collateral circulation, but I've not seen that demonstrated compared to their blood pressure. So I think we could look at that within this study, and I think that'd be interesting. Thank you for the suggestion.
Thank you for all of the questions. We're going to move on to the next paper now.
So the next presenter is Dr. Ali Hani Hakim, speaking to us about insights into the role of bone in ischemia reperfusion events and its implications for outcomes in peripheral artery disease.
Hi, everyone. I'm Ali. I'm one of the third-year general surgery residents at the University of Nebraska, and I'm presenting our work on behalf of the peripheral artery disease team, research team at Nebraska. So Dr. Pipinos has the following disclosures. So the dynamics of oxygenation in bone and muscle tissues in the limbs of patients with peripheral artery disease remain inadequately elucidated, thus impeding a comprehensive understanding of the response of these tissue as well as the entire limb to acute ischemia and subsequent reperfusion events. In this study, we employed near-infrared spectroscopy during our post-occlusive reactive hyperemia testing to simultaneously assess bone and muscle tissue perfusion at rest and during ischemic stress in a swine model of hind limb ischemia. So just as a note for the anatomy of the pig, one unique feature is that bilateral internal iliacs come off of a common internal iliac trunk with the external iliac arteries coming off separately. So looking at the model of swine hind limb ischemia that we generate, in this study we had 8 Ossabaw swine that underwent right hind limb ischemia induction via endovascular coil occlusion of the right external iliac, right femoral, and right popliteal arteries. For these swines, before the induction of right hind limb ischemia and 4 weeks afterwards, we do our PRH testing using infrarenal aortic occlusion with a Fogarty balloon for 5 minutes. And while we are occluded, we measure the oximetry changes in the gastrocnemius muscles and the metatarsal bones using our near-infrared spectroscopy. On the right, you'll see a video of an angio of our aortic occlusion, and on the left, so you see both probes attached to the legs. The upper probes are actually attached on the calf, right below the knee, and then the lower probes are attached below the ankle at the level of the metatarsal bones. This is a kind of data that we track once our probes give us the data. And so what we see here is you see a baseline followed by occlusion start, and then with occlusion there's a drop in StO2, which we measure the maximum drop of StO2. We then look at the area under the curve to look at the oxygen deficit incurred within the 5 minutes, and then we record the recovery slope, meaning the rate of recovery at reperfusion once the occlusion ends, and the area under the curve after the occlusion, and that is to assess the hyperemia response. This is a kind of real-time tracing of what happens in the bone at 4 weeks. In black, you have the control, and in red, you have the ischemic bone. And even in this one sample, you see that there's a lot less drop in the ischemic bone. There's a slower drop, and then there's less oxygen deficit, and there's a lower recovery with a very attenuated hyperemic response. Now, looking at the data, before Heinlein ischemia, before induction of the Heinlein ischemia, both in the muscle and in the bone, you see when comparing the right versus the left, there are no differences in any of the main category of metrics that we measure. There are differences between the muscle and the bones, and we'll be presenting those on later Saturday. Now, looking at 4 weeks, after 4 weeks of ischemia, here is where a lot of the differences happen. If you're looking at both the muscle and the bone, you see that the ischemic leg has less percent drop-off symmetry, has less oxygen deficits, has a slower recovery slope. Having said that, the bone has a very important unique feature in that the hyperemic response in the bone is actually a lot less attenuated, and you see a much bigger difference in the bone compared to the muscle. So kind of summing up our findings, during stress testing, bone and muscle in the ischemic hind limb both showed reduced metabolic demands, and we know that by the lesser oxygen deficit incurred during ischemia, and also diminished reperfusion responses, meaning the rate of recovery after occlusion compared to the control hind limbs. However, the ischemic bone demonstrated an important additional aberration, namely the attenuated hyperemic response, indicating potentially more severe metabolic disturbances and reduced capacity to adapt and recover from ischemic stress compared to the ischemic muscle. Our findings highlight the often overlooked role of bone in ischemia reperfusion events and its potential significance as a determinant of outcomes in PAD. Currently, we are studying this a little further, and we intend to investigate the mechanisms that are behind the reason why the different tissues have differential responses to the ischemia. Additionally, we are using this tissue response in assessing some of the emerging therapies that we test on our models of PAD in our swine. Namely, we're trying pharmacologic agents, exercise therapy, revascularization, and more currently, the stem cell-based therapy. We would like to thank the MVSS Selection Committee for allowing us to speak here today, and I would like to thank Dr. Pepinos, my PI on this project, and the rest of the PAD research team at Nebraska helping me in this project. Thank you very much for your attention. I'm happy to take questions.
So this paper is open for discussion. While we're waiting, can you help us understand what will be the clinical translation of this? I agree that there is, the bone may have a lot more time to recover, or there could be some separate different pathways, but how do you foresee this moving into the translation elements?
That's a great question. So currently, right now, when we're considering patients with PD, we don't really understand bone health in general as one of the main contributors to the disease. So one of the things that we would like to do is to understand how all of the, in the human, we want to transition this to understand how all of the tissue is responding, because let's say you have a patient with a wound or a patient that's undergoing an amputation. Do we know exactly what's the contributor of the bone to the overall wound healing? At this point, we don't, and we'd like to find a way to be able to assess that before planning an operation for a patient. Second, we also don't understand the overall effects of PED on the hematopoietic potential of the bone. So are these patients becoming anemic because there's a bone that has PED for a long time that's been inflamed? That's one of the things that using this technology we're trying to develop.
In your experiments, did you do any analysis to analyze the bone marrow after the...
At this point, in our swine model, we have not. This is one of the things we are looking into next.
Outside.
So, Ali, congratulations on this study. I don't think people understand how hard it is to work with Asabal pigs. I have. These are pigs that have tusks and really coarse hair and are not really easy to work with. So congratulations on a study on these sorts of animals. But I'm curious what you mean by bone. Are you talking about the mineral component of the bone, or are you talking about bone marrow, where the component of blood resides? And more importantly, how would you investigate this in humans? Can you do it off a CT scan or MRI, or do you have to use the probes that you used on the pig?
That's a great question, and that has to do with in the technology, the depth of the light that penetrates dictates the level of the tissue that you're able to assess. In the particular one that we have here, the MOXIE that is commercially available for research, the depth of the light, in our opinion, penetrates the cortex and then comes back out. It doesn't quite assess the medulla, and that's A, because of the probe, and also B, because the cortex is very dense and light has a very difficult time coming through in and out of it. So that was one of the very difficult challenges when we were coming up with this project, and how do we actually, are we able to do this with the technology because of the nature of the bone?
All right. Thank you all. So we'll be moving on to the next speaker, which is Dr. Hakim again. He'll be speaking to us on contemporary iliac DVT invasive management, lower post-thrombotic syndrome incidence than ever before.
All right, switching gears, looking into our work in the DVT space. We have no disclosures for this talk. The role of invasive intervention for the management of proximal DVT of the lower extremities continues to be debated. Prior studies failed to show the superiority of catheter-directed thrombolysis compared to anticoagulation in preventing post-thrombotic syndrome in all comers. Particularly the ATTRACT trial did not show any superiority of catheter-directed thrombolysis compared to medical treatment alone. Specifically, in this trial, they showed a rate of PTS of 18% for catheter-directed thrombolysis patients. So, as I said, but one of the things, though, that the previous study have not delineated is the role of clearance of chronic clot in the management of these patients. In our experience, when we do these thrombectomy procedures, we have noticed that the extracted clot demonstrates a heavier chronic clot burden than we anticipate based on the symptoms and the presentation of the patient. Here I present a case of a 28-year-old woman who came in with less than 7 days of symptoms. Initially, she was getting worse on heparin, so we took her to the operating room for a mechanical thrombectomy with Clotriver. And essentially what we find is all this large amount of black chronic clot, which is not what we expected. We were able to successfully recanalize her, and you can see the postoperative CTV here with patent IVC down to the popliteal. When she presented, as you see in the first picture, her system was occluded from the IVC down to the popliteal bilaterally. So with the advent of the newer generation of thrombectomy devices with better chronic thrombus extraction, we hypothesized that PTS incidence and severity would be lower than prior studies. To do this, we did a retrospective analysis of all the patients that underwent surgical management to address symptomatic iliac DVT at our institution from 2020 to 2023. We had 46 patients in this cohort. The intervention consisted of Clotriver, Inari, or Cat12 penumbra thrombectomy with or without catheter-directed TPA thrombolysis to clear a clot burden. Postoperatively, we followed the patients with ultrasounds at 1 and 6 months to assess vein patency, and we saw them in clinic to assess their response to therapy. Preoperative data, we saw that our average patient was 58-year-old. The majority of the patient at 93% presented with multi-extent DVT, including iliac, femoral, and popliteal veins. 28% presented with PEs, 13% presented with May-Thurner syndrome. Preoperatively, all the patients had edema, 80% had pain, and we had 2 patients that presented with phlegmasia. Operatively, the first big finding we found is by using the Clotriver system alone, we were able to effectively clear clot in 78% of our cases. In the cases where we had to, in 15% of the cases, we had to use thrombolysis, and the reason for that was technical in nature, as is outlined in the line below. Stent usage was very low at 17% initially. And then the majority of these cases were able to be done under monitored anesthesia care at 72%, with 70% of these cases being done in the prone position. Postoperatively, our patients stayed in the hospital an average of 1.7 days, with a median of 1 day of stay. In all 46 patients, we had 0 major bleeding complications. In terms of follow-up, clinical follow-up, we had a median follow-up of 221 days. And then we assessed the patients for PTS using the Vialta score of greater than 4. And essentially, we had 3 patients, meaning 6.5% of patients through the entire cohort that developed PTS afterwards. 70% did not have any edema, and 90% did not have any pain afterwards. Looking at the ultrasound data that we have collected, one of the major talking points for us is looking at the iliac vein. At 1 month and at 6 months, respectively, we had patency of 95 and 91%. And then looking at reoperation, we had 5 reoperations that all happened within the first 4 months. Afterwards, the patient didn't typically require reintervention after that. And then our freedom from reoperation beyond the 4 month was 86.3%. Obviously, this study has multiple limitations. This is a single-center retrospective study. We have no control arm, and we have no consistent quantification of vein reflux in this study. Having said that, we believe that mechanical thrombectomy of lower extremity DVT is associated with a decreased need for thrombolysis, a low rate of bleeding complication, and excellent patency through 6 months. We demonstrate that lasting vein patency with lower rates and severity of PTS than previously reported, with a judicious use of venous stenting. Future direction for us include longer-term follow-up for our patients and studying the clot characteristics under a microscope. But we do think that given our results, this would warrant further investigation of contemporary techniques to address iliac DVT in the scope of a more formal clinical trial. Again, I would like to thank the MVSS selection committee for letting us present our work, and I would like to thank Dr. Cook, my PI on this project, and the rest of the DVT research team at the University of Nebraska. Thank you, everybody, for your attention, and I'm happy to take questions.
Paul Chrysostom, Loyola. I found the Flash 2.0 of the CAT-16 to be an order of magnitude more efficacious than the old CAT-12 of the Penumbra. Have you guys started using this newer device, and what is your expectation with the outcomes with the newer device? I mean, it's not just, in my hands, not just a little better, but considerably better than the prior CAT-12. That's question 1. Question 2 is, I think some of the residual PTS may come from the calf DVT. I think a lot of us that do these procedures do it prone. We access the POP. That's how Dr. Montaganahalli taught me once upon a time, a long time ago. And I think a lot of us don't address the tibial DVT, which could be a source of residual PTS. What are your thoughts on addressing the tibial DVT at the initial time of the operation? Thank you.
To answer your first questions, we have not tried the CAT-16, so I don't have a great answer for that one. Regarding the tibial DVT, we actually have measured our residual thrombosis in the tibial soleal veins, and it's about, at 6 months, it's about 80 to 85% patency, which underperforms the overall rate of PTS. So in our minds, actually treating the more upfront disease in the iliac is what's leading to overall better drainage in the leg to prevent PTS.
Thank you very much, and nice presentation. Your study is showing different results from almost all the major 3 studies, that the residual clot doesn't make a difference if you open it, except one of them showed that it might make a difference, which means the attract, the cava, the other ones. So also your study is different than the cloud registry, which was 92.1% almost success rate. So why do you want to add that thrombolysis, which causes most of the complication, to a thrombectomy that removes most of the clot in 17, 18 minutes even?
Great question. There are cases where trying to get the inari clot retriever up and above is very difficult. Meaning we had cases of complete occlusion of the IVC where we're not able to pass a clot or to be able to pass the IVUS above to drop the basket above. And there were cases of things like IVC atresia where we're not able to do this. So in those cases where there's a technical issue with being able to get the basket up, we do utilize the thrombolysis to try and soften the clot so we're able to pass it 24 hours later and perform the procedure.
So we're out of time for further discussion. I apologize. Our next, thank you very much for a great talk. Our next paper is Long-Term Outcomes from 2 Decades of Endovascular Aortic Repair, presented by Suma Gandhi from University of Missouri.
Thank you to the committee for the opportunity to present. My name is Sham, and I'm an M4 at University of Missouri, Columbia. These are our disclosures. So EVAR is currently our current preferred standard treatment for those with abdominal aortic aneurysms. We've had multiple trials over the past several decades that have shown this initial survival advantage over open repair. And as you can see through the decades, we've improved in our graft technology, thereby reducing some of our graft-related complications, which were seen in the earlier generations, including migration and endoleak. This active fixation, including the barbs and hooks on the endograft, allow fixation to the aneurysm and thereby decrease the reintervention rates as well as we go on with the graft availability. And so the objective of our study is to retrospectively evaluate outcomes of EVAR over 2 decades at our institution. We did chart review on patients that underwent infrarenal EVAR between 2000 and 2022. We included demographic information, graft information, and intraoperative data. We did outcomes measurements, which included a subgroup analysis broken down into symptomology, sex, graft size, and era of repair. Overall, there were about 500 patients in this cohort, the average age being 72. About 1/5 of those patients were female. About 1/3 of those were symptomatic at the time of repair. And 28 millimeters was the most common graft that was used. Indications are on the table to the right. Overall mortality in this cohort was about 18%, and this was throughout the total follow-up period, which is about 60 months on average in the cohort. About 7% of those were aneurysm-related deaths. Leg ischemia, endoleak rates, and reintervention rates were also low, listed below. We did subgroup analysis of this cohort based on sex, and so when taking a look at the demographics, there wasn't necessarily too much of a difference. There were more females that had EVAR for aortic thrombus and more males on average that had EVAR for just simple aneurysm repair. What difference that we did notice was that females on average had a smaller graft size that was used. We looked at the outcomes based on sex and found that if you were a female, you had a higher chance of 30-day mortality as well as 30-day complications and overall complications in this cohort. Complications include leg ischemia, wound infection, and mesenteric ischemia as well. If you take a look at the overall mortality, it is not significantly different between the 2 genders. When taking a look at the outcomes based on symptoms, patients that were symptomatic were more likely to have mortality at 30 days, 30-day complications, and overall complications as well, including pulmonary failure and leg ischemia. Interestingly, endoleak was the only thing that wasn't significant in symptomatic patients. We took a look at outcomes based on graft size, and so we broke up the subgroup into smaller graft sizes, which was 28 millimeters or less, and larger graft sizes, which was larger than 28 millimeters. Those that were larger had a higher incidence of MACE, open reintervention, and endoleaks as well. Lastly, we took a look at our cohort based on earlier or later repair. Earlier was prior to 2012 and later was after 2012. If you take a look at our demographics, by age, we operated on younger patients in the later years of the cohort. We also operated on more symptomatic patients in the later years of the cohort. In the later years, we also got more comfortable and had more varied indications for surgery. And then taking a look at the intraoperative parameters, those also changed with the evolution of EVAR. In terms of 30-day outcomes, there was no real difference that we had found. However, with overall outcomes, mortality was significantly less in the later group, as well as endovascular reintervention. Lastly, we did 6 logistic regression models, multivariable analysis on those that were significant in the unadjusted outcomes. And so dissection symptomatic patients and diabetes was associated with having an increased risk of MACE. Same thing with age and diabetes being an increased risk factor for mortality. There were no independent risk factors associated with renal failure. However, diabetes was associated with leg ischemia. And interestingly, being female was actually a risk factor in this cohort of having leg ischemia. There were no independent risk factors associated with reintervention, though patients that were older had more significant risk of endoleak, and patients that were symptomatic were actually protective against endoleak in this cohort. These are our Kaplan-Meier survival estimates based on sex. There was no difference in this cohort. Based on symptomology, there was a significant difference. And then based on graft size, there was a significant difference with those patients that had a larger graft size having a more higher rate of mortality. In essence, we had a low intervention and endoleak rate. Most of the complications that we saw were associated with being female, being symptomatic, and having larger graft sizes. The reintervention rate and endoleak were associated with the graft size being larger and the era of repair being earlier. Mortality was also associated with this increased graft size as well. So overall, what we learned in this study is that the further we developed our experience with EVAR, we expanded our indications for EVAR and reduced our reintervention rate and mortality rate as well. Some things such as female patients still having worsening outcomes are things that we're still looking into. Some of this may be likely purely anatomical because of smaller limb grafts, but still more to look into. And then lastly, mortality is associated with larger endograft size. We think that this may be due to patients that have a larger aortic neck size having a marker for poor patient survival. Thank you for listening. I welcome any questions.
Rossi from Milwaukee. That's well presented. So what drove that mortality difference later on? Is that aortic-specific mortality, or was that just mortality in general? Because your endoleak rate was quite low. So why is it, in general, do you think, that you see that big difference in mortality between the two graft sizes? Thanks.
Yeah, so I think one of the things that we looked at when looking specifically at mortality based on graft size is the patient population that utilizes the larger graft size. And so in terms of the mortality itself, 18% kind of encompass mortality of any sort. And so that included things like respiratory failure, infection, post-graft, other traumas, et cetera. And so the patients that had simply aneurysmal related death, that was 7%. We did not look specifically at whether or not that 7% aneurysmal related death was associated with the larger graft size.
Frank, great talk. If you look at EVAR over time, IFU plays a role, right? So early on, everyone followed IFU, and then we got kind of crazy, and then we realized we shouldn't be that crazy, and got back on IFU. So did you think about like looking at IFU adherence throughout the time, and maybe the wide neck was the fact that you're trying to put a big graft and a big aorta, and maybe not necessarily IFU. So I think IFU adherence would be interesting to see. So
I think I can probably fill that, Frank. So we were just talking about this before as one of the predicted questions, because you're absolutely right. Early on, the grafts weren't great. We were sticking to IFU. And then as you got more experience with it, you're absolutely right. People pushed the boundaries and then realized that wasn't great with the advent of fenestrated and branch technology. So you see this swing. It's quite a big lift to look at 500 CT scans and then multiple additionals. And so we just don't have that capability. I mean, when you do industry studies, there's a core lab that you're paying millions of dollars to do it. So, but I've been thinking about that because I would love to see how our indications have changed. So I can't answer that for you today, but perhaps if I get some students who are brave enough to look at, 3,000 CT scans, then, we might have that answer. But I'm glad you asked that question. And just to answer Dr. Rossi's question really quickly, I don't think we can explain the difference in mortality purely on the small amount of aneurysm-related mortality. That's why I put in the end, when we were talking about things, that I think it is a true marker of a patient population that is sicker and not going to survive as long. So just having a large neck is probably a bad mortality predictor.
So lots of discussion on this one. We're going to pause any further questions, and I encourage you to find our authors during the next break. But we're going to move on to our final abstract.
So the last paper for this session is from Joshua Meredith. Preoperative ECMO cannulation confers decreased mortality in high-risk pulmonary embolism.
Thanks for having me. We have no disclosures pertinent to the topic. Just a little bit of background. So pulmonary embolism remains the third leading cause of cardiovascular mortality worldwide, despite numerous interventions and changes in practice throughout the world. And although catheter-directed lytics and systemic thrombolysis have shown some success, the bleeding risk is still significant, with up to 8.9% with systemic lytic therapy and with about 3 to 6% with catheter-directed lytics. Aspiration thrombectomy has the benefit of mitigating some of this hemorrhage risk, although these large devices that are more effective can cause significant distortion of the right heart and increase the risk of cardiovascular collapse and death. In the subset of high-risk PE patients, cardiovascular collapse and death are exceedingly high, with most publications quoting around 20% mortality, with some publications up to 60% mortality. These patients are obviously at high risk of cardiovascular collapse and death with any further distortion of the heart, such as when passing a large bore catheter or sheath through the right atrium and ventricle into the pulmonary arterial system. So our objectives were to basically evaluate the effectiveness of aspiration thrombectomy and computer-assisted vacuum thrombectomy and mechanical thrombectomy devices, as well as to determine if larger devices can precipitate cardiovascular collapse and death. In the subset of high-risk PE patients, our hypothesis was that preoperative ECMO cannulation would mitigate some of the risk of mortality in these patients. Our study was a single-center retrospective review of 106 patients with intermediate to high-risk PE. These patients underwent aspiration thrombectomy, computer-assisted vacuum thrombectomy, or mechanical thrombectomy from 2018 to 2024. Two groups were created. One was a small bore aspiration group, including patients who underwent 6 or 8 French aspiration thrombectomy. And then the medium to large bore group included patients that underwent 12 French, 16 French, or 24 French aspiration or mechanical thrombectomy. The primary outcomes included rate of cardiovascular collapse, single session therapy defined as successful thromboembolectomy without the need for adjuvant thrombolysis, and overall mortality. Regarding high-risk PE, 13 patients in our data set were high risk due to the hemodynamic compromise on presentation and underwent thrombectomy. The two study groups in this data set either underwent preoperative ECMO cannulation or did not. The primary outcome was overall mortality in this group. This table is a summary of small versus medium to large bore devices. The age, sex, RV-LV, presence of reflux of contrast into the intrahepatic IVC, moderate to severe RV dilation, and moderate to severe RV dysfunction, as well as TAPSE, were found to be similar between all the groups. Regarding results of the first analysis, moderate to large bore devices were found to be more efficient at thrombus removal with single session therapy rates over 90% compared to 33% in the small bore group. This was found to be statistically significant with a p-value of less than 0.0001. Rates of cardiovascular collapse were found to be similar between the groups statistically, despite a 0% rate in the small bore group and a 10.3% rate in the medium to large bore group. And then mortality between the groups was found to be similar as well with a p-value of 0.404. This table essentially summarizes the high-risk patient population in our study group. Basically, for the high-risk PE subset, similar data was collected, including patient demographics and preoperative clinical data. The group without preoperative ECMO cannulation did have a significantly higher percentage of females, but otherwise all other factors were similar between the groups. Overall, these patients were intuitively found to do much worse than the intermediate risk group, with an overall mortality of 38.4%. Patients who suffered a mortality were found to be older on average, with an average age of 67 compared to 58.8. The above graphic demonstrates the ages of the study patients, with green markers designating the mortalities and blue the survivors. The age difference, however, was not found to be statistically significant and did not correlate with mortality overall, with a correlation coefficient of 0.42. To determine whether the patients who died had preoperative cardiopulmonary dysfunction, mortality rates were evaluated based on prior echo. Pre-existing cardiopulmonary disease was not found in higher rates in the patients who had died in our study. Mortality was found to occur at higher rates in our female patients, with a rate of 63% in the high-risk PE subset, with a p-value of 0.024. And then the final analysis was completed based on preoperative ECMO cannulation versus without. The patients who underwent ECMO cannulation prior to thromboembolectomy were found to have a mortality rate of 0% compared to 62.5% in the non-ECMO group. This was found to be statistically significant with a p-value of 0.024. In conclusion, thromboembolectomy was more successful with larger bore devices without significantly increasing rates of cardiovascular collapse or mortality. Female sex was noted to be a negative prognostic indicator in high-risk PE patients regardless of the type of intervention. And finally, preoperative ECMO cannulation confers a significant mortality benefit with high-risk PE undergoing endovascular intervention. Here's some of my sources, and with that, I'd like to thank you for having me up here and take any questions.
First of all, great session again. All the topics were awesome. Not really a question for you, but a clarification. As the senior author, that's my oversight on the disclosures. A couple of us do talks for Penumbra in particular. So that's my error as a senior author. But despite that, I would encourage you, don't really listen to any of these companies when it comes to high-risk PE. These folks are ill. If they're not on ECMO and you take a large bore sheath through that right heart, it distorts it, and you'll take a patient that perhaps would have passed away without ECMO in the ICU, and you'll be the cause of it. We've unfortunately had it happen to us a couple times. When you take a large sheath through that right heart, the contractility changes, and you'll be coding them literally in the cath lab. So just a comment about that.
Nate Rose, University of Utah. Thank you, Dr. Muck and team, for a presentation. How are you guys using this information for resources? We had this discussion a lot in St. Louis of what patients truly need ECMO before going to the lab. And we got a lot of pushback from cardiology about them being on call and using their perfusion teams consistently. So how is Good Sam managing that problem?
We really haven't had a whole lot of pushback, and with the cardiothoracic surgery team in particular, they are completely on board with preoperative ECMO cannulation rather than rescue ECMO cannulation.
Nice of them.
Yeah, we utilize Viz.AI as a software to help identify PE, and essentially all these parties are involved from the beginning, about 4 minutes after the scan is completed.
Yeah, I would encourage you to engage the cardiologist because they also have right-sided, right heart impellers that they can use as well. ECMO is better, but if we're getting pushback, talk to the cardiologist about that. Because again, even in intermediate high-risk PE, where you see contrast refluxing into hepatic veins, those patients are on a banana peel, and you could be the one who pushes them over the edge. And like I said, I've had it happen to me twice, and it is not a fun feeling at all.
Okay. Last question here, Zayed.
Great question, great study, and I'm curious, did you stratify your analysis by submassive versus massive PE patients? Because, well, you know, certainly if the PE is large and the patient is already compromised and is in shock, that's different than a patient that's stable but has intermediate risk. And then I'm curious, you know, in preparation for potential ECMO, do you get arterial cannulation or veno-venal cannulation in case the patient does develop hemodynamic compromise or shock intraoperatively?
So the patients that we have cannulated preoperatively for ECMO, we've essentially placed them on VA ECMO before we intervene at all. So that's currently our practice. With regard to your first question, for the high-risk PE subset, it was all massive PE. Essentially, that only included the high-risk patients that were hemodynamically unstable.
Okay, with that, the session concludes. So we're going to reconvene here by 3:55. Dr. Miller has given an extension of 10 minutes. Thank you.